Okay, ladies and gentlemen, our next chapter is Chapter 10, Medical Complications in Pregnancy. We're going to look at a variety of medical complications, and we're going to start out with cardiac disease. Now, I have in my library a book on cardiac disease in pregnancy, which is about 2 inches thick. And we're going to go through this in less than 10 minutes. What do you need to know about cardiac disease in pregnancy? Here's our case. A 30-year-old multigravida with a childhood history of rheumatic fever has echocardiography diagnosed mitral stenosis. We'll come back to that. Mitral stenosis. She's now 20 weeks gestation, has no symptoms at rest, but has mild shortness of breath and dyspnea with activity. What classification of the New York Heart Association classification of heart disease in pregnancy is she? 1, 2, 3, or 4. And she is numero dos. On exam, she has a diastolic murmur, which we would expect. When we look at various kinds of heart disease, coronary heart disease is rare because patients who have coronary heart disease are usually too old to have babies. The concern there is hypoxia. Rheumatic heart disease is common in pregnancy. The big problem there we'll talk about is decreased diastolic flow. Congenital heart disease is not very common either. And that is variable depending on whether it is cyanotic or non-cyanotic, and we'll talk about some of those in detail. The most common acquired heart disease in pregnancy, not necessarily acquired during pregnancy, but it's the most common heart disease which is acquired in pregnant women, is rheumatic heart disease. The kind of rheumatic heart disease that we see is mitral. The most common with the mitral valve is mitral stenosis. And the big issue is slow diastolic filling. Let's look at that. This shows a cardiac cycle. We have diastole, we have systole. Diastole and systole. And the heart rate here is 80 beats a minute. I want you to notice the relative length of each of these. This is one cardiac cycle. Here's a second cardiac cycle. Let's increase the heart rate to 120 beats a minute. Does the length of systole change? No. The amount of time it takes for the heart to contract stays the same. It is the diastole which shortens. Do you see that? And the faster the heart rate, the less time there is during diastole. Systole is unchanged, but diastole is shortened. What are the factors that worsen mitral stenosis? Increase in heart rate, increase in blood volume. What are the normal changes of pregnancy? Increase in heart rate, increase in blood volume. Do you see a problem here? The same factors that worsen mitral stenosis are the normal changes of pregnancy. These do not go well together. Mitral stenosis and the normal changes of pregnancy, which is increase in heart rate and increase in plasma volume. Let's just review briefly the normal physiologic changes of pregnancy. Plasma volume goes up 50%. Heart rate goes up 15%. Stroke volume goes up 25%. Cardiac output goes up 40 to 50%. Peripheral vascular resistance decreases. This is going to be important as we look at our various heart diseases. The most common congenital heart disease in pregnancy is atrial septal defect, ventricular septal defect, and frankly, you don't need to worry about those. These patients do well in pregnancy. Anytime you've got a regurgitation lesion, pregnancy should be no problem. The most common congenital cyanotic heart disease is tetralogy of Fallot. If it is corrected, and most of these are corrected in childhood, patients should do well. Uncorrected, big-time problems. When we look at maternal mortality risk, ASD, VSD, corrected tetralogy, very low complication rate. The highest mortality rate is with Eisenmenger syndrome and Marfan's with a dilated aorta. The unique high-risk conditions are Eisenmenger syndrome, Marfan syndrome, and peripartum cardiomyopathy. Each of these have potentially a 50% mortality risk. Let's start out with Eisenmenger's. The problem here is you have pulmonary hypertension. There is increased resistance in the pulmonary vascular bed. In order to get the blood to go through into the lungs, you've got to generate a high pressure in the right atrium. The other finding with Eisenmenger's is that there is an intracardiac shunt, which can allow the blood to go either from right to left or left to right. Now, what happens in Eisenmenger syndrome? The pulmonary hypertension does not change, but the peripheral vascular resistance drops. If the resistance in the pulmonary circulation is higher than the resistance in the peripheral circulation, the blood will say, why should I go through the lungs? A far easier way is for me just to go through the shunt, and you have unoxygenated blood going from the right heart into the left heart, out into the body, and that's what you call shock. Decreased oxygen transport. This is a positive feedback spiral downward, and this patient dies. The big problem with Eisenmenger's is avoid hypotension and decreased systemic resistance. Marfan syndrome. If the aorta is dilated over 4 centimeters, 40 millimeters, increased risk of aortic dissection. And the reason is that as the diameter of a vessel increases, even though the pressure inside is the same, the tension in the wall increases as the square of the radius, Laplace's law, if you remember that. This is a big issue, aortic dissection. Surgical reconstruction. I would advise a patient with Marfan syndrome not to get pregnant. The third high-risk cardiac condition is peripartum cardiomyopathy. This is idiopathic biventricular cardiac failure. Now, if we look at what side of the heart has trouble in Eisenmenger syndrome, it's the right side of the heart, because you've got to overcome the pulmonary resistance. Which side of the heart gets into trouble with rheumatic mitral stenosis? It is the left heart, because the mitral valve backs up the blood into the lungs. In peripartum cardiomyopathy, it is biventricular, both sides of the heart, the left and the right, and the heart becomes large. The ejection fraction, I've seen some of these patients have an ejection fraction which should be 65%, 10, 15%. The heart is barely moving. Now, what does it mean, supportive care? There's not a whole lot specifically you can do other than to strengthen the cardiac function as much as you can with inotropic agents, try to maintain systemic perfusion. If she does not recover within 6 months, 50% mortality. This is a normal heart pumping, and you can see blood comes into the heart, into the left atrium, I should say right ventricle, and this is a normal intact septum. The blood goes up through the pulmonary artery into the lungs. Here's what happened with Eisenmenger syndrome. The blood should go up into the pulmonary artery from the right ventricle, but instead what happens? The blood goes through this shunt, which is in this VSD, and unoxygenated blood goes out through the aorta into the systemic circulation, and you've got shock, hypotension, and the patient dies. We had a patient recently who died from this at our hospital. Here we have long fingers. What do you call this? Arachnodactyly. Arachnodactyly spider fingers. This is Marfan syndrome. This is a patient that I had, 30-year-old woman, 5'9" with scoliosis. What do you think she would be without scoliosis? Probably close to 6 feet tall. Can you do this with your finger? It's about all I can do with my finger. Very lax joints. And the concern is aortic dissection. Patient with scoliosis because of the connective tissue disorder, and this is a problem that you develop with the aorta. This is biventricular cardiac enlargement. This is a normal-sized heart. I'm going to superimpose this heart on the cardiomyopathic heart, and you can see huge heart, but does not pump very well. When we talk about symptoms of cardiac disease, we want to ask these to patients when they come in. Severe dyspnea, orthopnea, hemoptysis, syncope, chest pain. These are going to be very important when we evaluate the patient in terms of classification of functional heart disease. In terms of signs of cardiac disease, systolic murmur. You should never have a really loud or pansystolic murmur, normally. You should never have a diastolic murmur. The heart should not be enlarged significantly. Cyanosis or clubbing would be evidence of cyanotic heart disease. Jugular venous distension is where you have right-sided failure. If you'd remember, bidirectional intracardiac shunt is suggestive of Eisenmenger's, not good with pregnancy. Dilated aortic root should make you think of Marfan syndrome, not good with pregnancy. Okay, this slide looks at the New York Heart Association functional classification of heart disease in pregnancy. I want you to notice it is functional classification. It doesn't look at the anatomy, it doesn't look at whether it's the right side, the left side of the heart, whether it's a valvular problem. It says, how is the patient doing? Does she have symptoms at rest? Does she have symptoms with activity? Class 1, no symptoms at rest, no symptoms with activity. Class 2, no symptoms at rest, mild symptoms with activity. These patients can typically deliver without being in an intensive care unit, delivering a regular labor and delivery, do not need invasive monitoring lines. Class 3 and 4, however, probably need to deliver in an ICU and with invasive lines. Class 3 is no symptoms at rest, but marked symptoms with activity. And Class 4, even at rest, is having symptoms that get worse. Now, a patient can start out in Class 1 and move to Class 2 or 3, so it doesn't mean it's going to be static. But it would be good to know the functional classification of heart disease for the USMLE exam. All right, let's summarize what we have just said. The most common acquired heart disease is rheumatic mitral stenosis. The problem is decreased diastolic filling. Management, minimize the increase in heart rate, decrease intravascular volume. How do you do that? Minimize the increase in heart rate by having the patient not get anemic. With anemia, you're going to increase cardiac output and heart rate. And have her at bed rest or at least limited activity to try to minimize the amount of cardiac work and also to mobilize extra fluid. ASD-VSD, the most common congenital heart disease, no problem in pregnancy, conservative management. Tetralogy of Fallot, if corrected, no problem, conservative management. Eisenmenger's, remember the big issues here is pulmonary hypertension and intracardiac shunt. Avoid hypotension, because if she becomes hypotensive and starts shunting across the heart and unoxygenated blood going out into the peripheral circulation, it's over. Marfan syndrome, big concern is the dilated aortic root, surgical reconstruction, and cardiomyopathy, biventricular failure. Try to get the patient to where they can themselves recover cardiac function. That's the end of cardiac disease in pregnancy.